Okay, well, welcome. Thanks for joining. We're about 2 after here, so I think we can go ahead and get started. Thanks everybody for joining us here in January for our roundtable discussion. For those that don't know me, I'm Brian Cottonsteady, and also on the phone from Make Solutions is Patty Marshall. We're both co-founders of Make Solutions, and so for those of you who don't know kind of about the roundtable, we have been doing these for probably actually just a little bit over a year now, and just as a way for various Cerner sites to get together and talk about things that are impactful to them from a nursing side. So allowing you to have an open forum and an open discussion to talk about things that you're doing, questions you have, concerns, but especially be able to share some of your best practices so we can all learn from each other here. So it's a very open dialogue that we have. The content is driven by what you guys bring up, and I throw a few things out there as well. But if anybody has anything, certainly we want to bring that up here and use this time for anything that is important to you. Kim, did you want to do a quick introduction before we get started?
Sure. My name is Kim Ramirez. I'm the Senior Manager of Clinical Systems at a company called Transform. We're a shared service organization that supports 5 hospitals in southwestern Ontario. We just went live with 3 of our organizations within the last few months, and we have our largest hospital left to go in the spring. So we are in the midst of doing some optimization work with the 3 sites that are the 3 organizations that are live, as well as doing the final preparations for the go live at the last organization. I'm a nurse by background. Spent a lot of years working in Emerge and moved into sort of the clinical informatics space, I don't know, give or take 15, 18 years ago, roughly.
Well, thanks for joining here this morning. I know you've got the 3 go lives behind you, but I think you have what, the 2 biggest in front of you still, is it?
So it's one organization with 2 major acute sites. Yes, April 11th right now is still the date, but I don't know, we just got thrown back into a significant lockdown here in Ontario, so I'm not sure if that might put a wrench into some things. We did remote support for the last go lives, but this one might be a little bit different, so we'll see. We're still planned for April 11th at this point.
Wow. Okay.
Yeah.
Good luck. Is there anybody else who's new to these that has an introduction? All right, well, Kim, you kind of did a good lead in there with talking about the lockdowns there. I had put on the agenda, I thought it'd be interesting for everybody to kind of talk about how they're doing some of their COVID vaccine response and some of the tracking. I know that's been a big concern at facilities. I was also curious as well if anybody's using Cerner's mass vaccination pages. I believe there's 3 or 4 of those out there, and then just how you're able to track those vaccinations and then making sure you're getting people back within the 21 or the 28 days for their second dose appointments. So I guess I'll start off. Is anybody using the Cerner mass vaccination pages, or is there anything that you'd want to talk about with those? Doesn't sound like anybody's using it then. I've only heard of a couple organizations that are using it. I know there has been some concern as well around some of the employee vaccinations and how you treat the employees with some of the health confidentiality that needs to go in place there. Is there anything anybody wants to talk about around how they're doing some of the employee vaccinations or tracking that, whether it's electronic or on paper?
This is Brian at UT Medical Center. We're doing an electronic registration of the employee if they don't have one. We tried to preload an employee list and create a medical record if they didn't already have one, because that has to be submitted to tennis within, I take 24 hours. So trying to do paper would have just made it a whole nother, one more step harder.
Great.
This
Chris,
is
were you
Cindy.
saying something?
I can just add, we're doing an electronic registration process too, but we're not using Cerner. We're using eClinicalWorks, which is what our primary care centers use, just for the registration of the first and second dose vaccination. And then we have a homegrown occupational health record that we're using as well.
Yep.
Yeah, this is Chris at Covenant. We've got kind of the same. We had some concerns about loading those employees into Cerner, so we did a homegrown version as well. Same thing that we used for the flu shot. We just added the second dose capability to that, and then we're using that to upload that.
And I'm assuming all this. Oh, sorry. Does somebody else have something?
Oh, hey, Brian, it's Ray Costello from Northside Hospital. We're doing the same thing. As far as employees are concerned, we're having them sign up on their own via Sign Up Genius, and then also for the consent, we have sent them a link to do their electronic consent, and we use a system called Agility, which is more of a employee health system, and we then collect that information from Agility, send it to the state through grids. Right now, we're doing a manual upload of the vaccination that we have administered, but state is ready for us to send those to vaccination by HL7. So it's not going to be a manual upload, hopefully soon. We haven't used Cerner yet because I think we're looking into using that potentially if we decided to offer administration to our patients, but it's all through Agility and manual for us too.
Has anybody had problems uploading that data to the state? I only ask because I'm here in North Carolina, and it's a very manual process for them here. They don't have a state registry set up yet, so it's been kind of a bear for them here. Any other concerns from anybody's various states?
Hey, Brian, it's Ray again. For here at Georgia, at the beginning, I don't think they were ready for the information to be received on their end. They were having a lot of setup issues. So as of late, they were ready, and I know it's the requirement to submit it 24 hours post immunization, but because they were not ready, we were just collecting all the information, and now they were ready to receive our manual upload and getting the HL7 set up. So yeah, we did. State had problems at the onset of it, but I think they're trying to do a catch up.
All right, that's good to hear.
Hey, this is Jenna from Central. Can you hear me?
Yes.
Can you guys hear me?
Yeah, we can hear you.
Okay. So we do the electronic registration. We have a sign up in Teams if folks want to sign up, but we also have the ability for them to walk in to get registered. And then we've built it in Cerner where we barcode scan and administer that medication, and we're able to upload that to the state.
That sounds like a fairly streamlined process there. That's great. All right, well, I appreciate everybody's feedback on that. I just thought it might be interesting to kind of hear how everybody else is sort of tackling that, and really kind of everybody who spoke up really has a little bit of a different process there. So it's interesting to hear that. And I'm glad everybody has something worked out now. One of the items, actually one of the very first meetings we ever had, we talked about IPOCs. And one of the things that we talked about was just some of the concerns that we had around nursing needing to have an IPOC for every diagnosis. That was something that one of the sites had been cited on because something like previous fall should have a fall risk IPOC. But then also some of the concerns that providers don't really go and use any of that information when they go and do their rounds. So I wanted to kind of open up the dialogue again to talk about IPOCs, because what I'd like to do is if we can create sort of a list of enhancements or things that we feel that could be improved as nursing uses IPOCs, I'd like to be able to wrap that up and get that off to Cerner so we can say that this group of, 10 different healthcare systems wants to provide this feedback around IPOCs. So I know Cerner is working on something called the one plan model, but I also want us to be able to give our feedback as well, because I do think it will be valuable. I do think they would listen to a large group of organizations like this sort of as a single voice, as opposed to everybody sort of saying the same thing up through your channels. So I know that's kind of a broad topic there in terms of IPOCs, but in terms of using IPOCs and as your nurses use it, are there any concerns that you have around their usage or their workflows, functionality you'd like to have?
I just think we're still stuck in that nick and knock verbiage from years gone by. And last time the Joint Commission came in here, they said nursing doesn't have any ability to think or make decisions. They just have to react to whatever the provider says to do. So why do we have to do plan of care if the provider is the one directing everything? And I think the way we've done it historically has never really truly changed the course of the path of the patient. So I think we do it because the Joint Commission says we have to do it, and it's really just a mundane exercise that we force them to do every shift.
Absolutely.
Yeah, this has historically, this has just been a bear to try to tackle, even from a regulatory standpoint. And I think that process of having to go and the workflow in Cerner, if you're using their IPOCs, it's a very cumbersome and clunky and time-consuming process. However, I do wonder if there's opportunity, to the point that you were making in regards to the Joint Commission, and there are plans of care set every day through orders. And is there some way to work with the functionality within Cerner to then craft those kind of orders into that plan of care, because those orders are essentially the plan of care for the patient. Now, there are other things that we will do for them, but I just wonder if there's a way, with all the planning that's occurring for the patient, how can that be incorporated into that plan of care, because you are essentially carrying out those plans. I don't know if I'm articulating what I'm trying to say, but it seems redundant.
That's a great, yeah.
Yeah, those orders never come into like a visual that, this power plan and this power plan and this power plan all have care orders, and that's the plan if they could all visualize somewhere to say, these are the things that we're doing.
Because they should ultimately address why the patient's there.
Yeah, it's getting done, and it's just not, like you said, doesn't paint a pretty picture, and it definitely is not face up. Clear.
I mean, it's a check the box, I think, is that. I mean, it's just very clunky. I mean, that we actually have a task force getting ready to come together to work through, because Cerner's been working on one plan for a while, and I thought it was going to release this quarter, but I haven't heard. Has anybody heard if they're close to releasing? And their first one's going to be in the ambulatory space.
I haven't heard.
So I have a meeting with Dorinda Friday, so I'll try to get an update on where they are with that one plan.
This is Simi. I would agree about IPOCs being really just cumbersome, and one of the things that we struggled with regulatory is the workflow that's associated with them. We have been cited about the progression on the care plan for the patient and goal attainment. And, you know, they looked at how our nurses were documenting, and they're saying, well, why are all of the plans, you know, goals met at the end of the stay? Why aren't you being more progressive during the hospitalization? And I think it's just like the earlier point of, it becomes kind of a check the box, and it really doesn't inform the practice of nursing as much as you would like it to. And so they don't go there and say, oh, okay, so, you know, the patient met this goal on day 2 versus all of the goals are met at the end of the stay. And so if there was some way to make it more face up and aligned with workflow documentation, I think that would be better. And we also haven't done any optimization with IPOC because we, you know, have been waiting for one plan, and we were told, oh, let's not spend time there. One plan's coming, and now it feels like it's almost been about a year and a half, maybe longer.
Yeah.
So.
And that's exactly what we did. We were going to build our own, and we thought the same thing. This one plan, and you know, and at first glance, the one plan looks like a pretty smooth workflow, but we're in the same boat. We're now, you know, it's January 2021, and we're still trying to figure out IPOCs.
This is Lori from Covenant, and I apologize for the road noise, but it is bright and early here in East Tennessee. I have 2 comments. Number one is, if Cerner can please not forget the conditions of participation for the psychiatric world, especially the geropsych, that the entire plan has to be reviewed by a whole group. We've had to do a lot of customization to make IPOCs go into a weekly review that has to happen. Number 2, if they can also look at the hospice world, they do a great job of having medical and nursing orders that cover the entire thing, as well as not doing what happened to us at Model in that respiratory therapy, physical therapy. Their plans of care are living on a power form somewhere and not integrated to the full plan.
Lori, thanks for that feedback on the hospice side. That's a great thought there. You know, if they're doing a good job, maybe there is something there that could be modeled from that into the acute side as well. Jenna, I really like your thought there around, could those plans of care be driven through some of the orders, and almost kind of makes me think of like orders to scheduling there, and you're placing an order and that turns into something else, or even if it doesn't turn necessarily into a plan of care, how does that become more face up to the provider to the nurse, to where that order does turn into that plan of care?
Well, and I think what Lori just said, what caught my attention with hospice is, I think, Lori, I don't want to misquote you, but I think you said nursing orders. And so that kind of opens up a whole nother thought process around, you know, it's not just the provider orders coming into whatever this is. Could we have nursing orders? Like, are we thinking about this not the way that it's conducive to a workflow by sticking it over here off to the side in its little silo? Yeah, I don't know. That's an interesting thought.
Yeah, Brian, the only thing I would add to that, this is Chris at Covenant as well, was if we're going to do a big ask, you know, consolidated like this, you know, to work it more into the nurse's workflow, you know, I would propose that they work on, you know, a mobile type app as well, you know, so it's anything we can do, I think, to ask as a group for nursing to get closer to the Power Chart touch type functionality. So, you know, is there any sort of mobile path we could take to get that, you know, available to them in the TC51s if we're going that kind of route?
This is Simi. I would agree. I think the inpatient or the nursing app on in CareWorks Connect, if that could be leveraged to allow for more timely documentation of these types of things in a more mobile way, so that and for them to be able to either have a visualization of those plans and how a patient's and what those goals are, maybe by date or by phase of the plan or something like that, that they could actually see, and it's more intuitive to them to document about them. And if that was available, not just for nursing, but for the OT, PT, social work, respiratory, whoever else might be engaged in that plan of care.
Yeah, that's a really good point as well, about pulling in everybody, all the different care providers. So making sure OT, PT, social work, they're all able to work off of that same care plan. Chris, I like your idea there as well about building it into that CareWare Connect platform. That way it is just heads up and gives that more visibility to anybody who wants to go see it. So you're not having to run back to a desktop to try and find that information.
Yeah, and I think to the earliest point about Joint Commission, you know, if you should turn that phone around and show them, hey, look, here it's all right here. You know, I think that would get that governing body, you know, on the same page as well.
Yeah, changing Joint Commission is probably a little larger than what this meeting will be able to accomplish. But if we can, like you said, fulfill the requirements of what they're looking for and make sure that they know that nurses are aware of that and they're managing that plan, I think that goes a long ways towards it, and not just checking the box, which is unfortunately what we're doing right now. Appreciate everybody's input there on the IPOCs. Is there anything else, any other thoughts that people have around IPOCs they wanted to talk about?
Hey, Brian, it's Ray. I do have a question. So with this pandemic, I don't know if any of you have implemented any disaster documentation that would help our nurses. Yeah, you don't have to do full reassessment type thing. And with that, also, do you know if Joint Commission is allowing for us not to do IPOC in the middle of the pandemic? I don't know if that's an exception, if you guys have implemented that.
So this is Jenna from Centra. They are allowing removal of the IPOCs if you go into disaster documentation. I don't know that they say if you go into disaster documentation, but we built that into our disaster documentation and are only requiring IPOCs for pain and restraints. And we significantly narrowed what our nurses are having to document. We are, it is very important. One thing that I have found in implementing the disaster documentation, because we did go to disaster documentation on January 7th for our healthcare system. And it's really important to stress that this is to relieve the documentation burden, not to change the delivery of care. So while you may only document a focused or patient condition assessment, you still do your full assessment for your patient. And if you have time, then by all means complete your full assessment. But we worked with our accreditation and licensure team to work through our policy and to ensure that we were still including the regulatory requirements, but we significantly reduced that documentation burden for our nurses.
Okay, thank you. That's helpful. That's exactly what we're doing. We're applying full assessment, but then on the reassessment, it's more focused. I was just curious about the IPOC. So that's a good point about just making sure we do pain for IPOC as applicable.
Yeah, we're doing pain and restraints. Our accreditation and licensure team really felt like we couldn't necessarily let those go, and so they're the only two that are still required.
Okay, thank you.
All right. I had another topic that I was going to bring up, but before I do that, just to make sure that I leave time for anybody, does anybody have anything else that they wanted to talk about? Any topics of conversation? You can certainly open it up.
Hey Brian, this is Ray. I do have a question maybe for next topic if no one has any thought around it. But the facility has a multi-facility. When let's say one facility a patient is getting a test in another facility, sister facility, because they just don't have the they don't have the equipment in one. Do you treat those as a discharge and then readmit? Because it's not really a transfer. And maybe it's because we use a third-party registration system also. But that's one of the complaints that we're getting from the physicians, that it's so cumbersome because they're not really discharging the patient. They're just trying to get the patient to another facility to get the test that they need and then come back. How do you do that process in your facilities, multi-facility?
So it sounds like a field trip.
Yeah, it is. So it's kind of like, because we use a third-party system, we can't really hold that fin. It's a different fin when you go to another facility, so you can't really hold that, so to speak. So you can't really do a transfer. So what we do now is we discharge and readmit.
That's what
Hey, this is Lori for this is Lori for Covenant. We have a third-party registration system, and I will be happy to share our workflow because we kind of trick the system, for lack of better words. But I'll be happy to send you that workflow. I don't remember it off the top of my head, but we do have one.
That would be wonderful. Brian, my email should be on this invite, but that would be wonderful if you could share that with us.
Yeah, Lori, that'd be great because Ray is STAR as well, so hopefully that transfers fairly easily. All right. Thank you. Ray, did you have anything else?
Yep, that's it. Thank you, Brian.
Yeah. Does anybody else have anything they wanted to talk about?
This is Simi. I was wondering, I wanted to ask if anybody had implemented the clinical driven revenue cycle, and post implementation, if they were having any trouble with patient accommodation codes. We've been finding that since implementation of the clinical driven revenue cycle that we've definitely been seeing some challenges with the accommodation codes not being, we're not really sure what the problem is. I think we're still kind of in an investigation mode, but definitely not seeing the revenues that we would have expected. And looking at the workflow, we feel as though our staff are entering the data accurately, but there seems to be something on the back end that perhaps it's a builder design issue, but we're not really sure, and just trying to work through that problem. And I was just wondering if anybody else has been having any issues with that as far as the rev cycle implementation that they did.
Doing a quick scan, it sort of looks like the ones who are using clinically driven revenue cycle aren't on today. CAMC has been doing it for a few years now. They might be good people for you to reach out to.
Okay, great.
Yeah, Centra is on the clinically driven revenue cycle too, and we implemented at the same time that we implemented everything else across the system. And we have had challenges with the clinically driven revenue cycle like everybody else, and we have consultants in with us trying to work through the accommodation order. I don't think we're having issues with that. So maybe initially when we launched, we did, but I can certainly reach out to I don't work in that space. But I can certainly reach out to the team and ask them if they have any, workflows or things or issues that they found that maybe would help you.
That would be great. Thank you.
Thoughts on the Research Council?
Yeah, and as Patty was saying, I know CAMC isn't on, and Concord Health as well also uses the clinically driven revenue cycle. I can ask them and see if they have any issues. I know they also had some issues that went live. I don't know specifically if they had any around the patient accommodation codes, but I'll ask Holly and see if she had any problems about that.
Personal and not quite as.
Somebody might need to go on mute there. We're hearing some background noise. Thank you. So, Sammy, we'll try and see if others here can help you out with that issue and maybe get that revenue back where you're expecting it to be.
Perfect. Thank you.
Yep. Anything else from the group?
Hey, Brian, this is Chris. I saw it on the agenda, but I just wanted to see if we could get from the group just some detailed information on Upgrade Center. We're close to doing some renegotiation for our Schedule 2, which is upcoming. And we're still using the Upgrade Center in some capacity, but I looked through the grid that the team put together, and I was hoping that we could get just a little more detail on, is everybody using the Upgrade Center in a full capacity, half capacity, if there's any differences. So I was hoping to hear back from the group today on those topics, if that's possible.
Yeah, absolutely. We could probably just run through everybody and everybody can kind of tell us how their organization is doing. We talked a little bit about this last time, but I don't think we ever got to the detail probably that you're looking for, Chris. So Jenna, did you want to maybe start out? You can tell us how Centra's doing it.
Yeah, we have not committed to our upgrade for this year, but the last upgrade that we did partner with the Upgrade Center, but it was we were right there with them. So they did not do our full upgrade. I would be very nervous if they were the only ones that were kind of working through that upgrade, because what I found with some other projects that they do with us is that they don't really understand systems and workflows. And from a project management side, there's some opportunity for them to really learn how to bring the healthcare system to the table to ensure that that what is delivered out is a quality product for the organization, for the system. We had a very successful upgrade using the Upgrade Center, but it is very much a project that has to be managed and working through all of the different things that don't work the way that it's supposed to, and really pressing them to get those fixed going into go live, so that you have a very successful go live that doesn't impact productivity, it doesn't impact significantly your caregiver's workflow unless it's in a really great way. But it is very much a partnership that you really have to stay close to them, because inevitably, if they do it all on their own, I'm not sure if other people have done that and been successful. That is great. We haven't had that experience with turning everything over to them for them to work through, but the hybrid works really well, I think.
Yeah, and that's true for us. That's kind of one of the reasons we're asking, because what we also want to get is that hybrid pricing, kind of as part of that. How many integration architects do you all have there in-house?
Well, we have one, and
okay.
Then we have one that is with Cerner. We have now hired on a second IA.
Okay. Thank you. That's very helpful.
You're welcome.
And this is Ray from Northside. I echo everything that Jenna said. We used the Upgrade Center when we upgraded last year. We're slated to go this year again. I believe they're scheduled in March, but I think we're going to use them also as a project. We're not, once it's done, then, then they leave. We partner with them. We have a couple of in-house Cerner experts that can help guide us with some of the integration pieces. So, for the same reasons that Jenna has said, it's true for us here at Northside Hospital.
Kim, how about up there at Transform? Are you using the Upgrade Center?
So we haven't done our first upgrade. We'll be slated for next fall, roughly. We're currently negotiating with them. So this has been good information for me. I would have the same concerns about sort of turning things over to them, just based on the experience that we've had even with the project, and the magnitude of the project and some of the challenges we've had with some of the resources from Cerner, let's say. So good to hear that I'm at least on the same wavelength from that perspective. But yeah, so as I said, we're probably headed into it next fall. This fall into the first quarter of next year, because we have to do one. But we've had so much work going on with this project that yeah, that's kind of where we're at.
Okay, great, thank you.
Yeah, no worries.
Simi, I think you said you use the Upgrade Center, is that correct?
Sorry, I was on mute.
No problem.
Apologize. Yes, we've used the Upgrade Center. In the past, they supported us when we did our upgrade this summer, last summer in August 2020. So yes. But
okay.
with Children's, we have the Bear Institute, and so we do have a little bit of a kind of an internal process as well as the Upgrade Center support.
Mm-hmm. Okay.
Yeah, and I don't know if this is true for the folks that are using the Upgrade Center. I'd be interested on your all's perspective with this as part of this as well. But the leverage we see that they have is just like everybody's saying. We're kind of managing the project, doing a lot of the testing and discussing the workflows. But it seems that they have the direct connection to escalate getting things fixed. And that'd be my concern, is not having that level of escalation. It just seems like an expensive way to go about getting it.
Yeah, Chris, I think your team would be responsible for logging all of those SRs and managing them, and hopefully getting somebody on the right team somewhere at Cerner to go and then look at those, which obviously, if they're not in a production environment yet, become a lower priority to anybody to work on. So, but
yeah, and it just seems odd that you have to pay for Upgrade Center to get that level of service.
Yeah, is it a six-figure service?
Well, either that or you have to be extremely good at escalating yourself. So the only thing I was going to say, Brian, was I know Simi mentioned the Bear Institute, but I don't know if everyone else knows what that is. So Children's is the only member of this group that's an IT Work site, right?
Yes.
And maybe everybody doesn't know what IT Works is either.
So, do you want me to explain it? Or actually, I don't know if Cindy wants to explain it.
Sorry, I'm trying to navigate major traffic going into DC. Apologize. Yes, so the Bear Institute does have IT Work site, and yes, we do. So the majority of our IT staff, about 90% of them, are actually Cerner employees that work on site at Children's. So that does provide us with a pretty significant support system with regards to all of our Cerner implementations and optimizations.
Great. Thank you for that additional explanation. And thanks, Patty, for reminding me that not everybody might be familiar with those terms. And Brant, I think you said we started here sort of before the call, you were saying that you do use the Upgrade Center and we're planning on using it as well. I know he had to sort of co-manage
Yes,
another call here.
I'm doing 2 meetings at the same time.
Yeah.
Yes, but I do think our people carry the brunt of that load of the testing and ensuring that after the upgrade that it all works the way it was supposed to work. So what do we pay them really for? But I mean, we have to ensure that it works. So I mean, I guess I don't know. I agree they should have a little more skin in the game for what we pay for.
Hey, Brent, how many integration architects do you all use over there?
I think we just have the one.
The one, okay.
For inpatient.
Yeah,
we may have one for the clinics. And
okay.
But I have to check with Dr. Callison.
I know they're not on, but I can speak for them a little bit. At Concord Health in New Hampshire, they also are using Upgrade Center, and Chris, very similar to what you're going through right now. There was a lot of debate whether their next upgrade, they were going to use the Upgrade Center, mainly because of the cost, not because of the quality of work that was turned out. But I know they negotiated for a new contract for their upgrade coming up here in the next couple months as well.
Thank you. That's helpful.
Yeah. All right. Anything else from the group we wanted to talk about? So I did have one other item. I may save it for our next meeting, but I just wanted to get into a little bit more detail and see if anybody's using ClearVia from a nursing productivity or to manage some of the patient acuity levels. I know that's a thing that I know a few of these sites are using or implementing, so I thought that might be a good area for us to kind of talk in a little more detail. I've got about 15 minutes left, so we could open that up, but otherwise we can save it for the next meeting as well. I guess I could say, how many of you are using ClearVia at this point?
So this is Cindy. We are using ClearVia right now only for Patient Assignment Manager. We originally, when we went live with ClearVia, thought about going live with acuity and with scheduling. At that time, given our scheduling workflows, we decided to stay on Kronos for scheduling and staffing, and so that does interface with our ClearVia for Patient Assignment Manager. We literally had a conversation yesterday to start talking about whether or not we want to move forward with acuity and are in the process of looking at what we had originally built out and mapped with regards to acuity. We are working on updating our HPPD and budgeted information in the system and are hoping to maybe turn it on in the background just to start to see how our current mapping work supports the acuity data and what that data looks like as we're also going through a lot of documentation optimization. But we're in the process for the acuity piece, but use it for assignment manager. And obviously with CareWork Connect, it allows for secondary notification of nurse call and physiological alerts.
That's great information. Thank you. The acuity piece is one that I always struggle with as well, because I know there's a lot of work that goes into that. You mentioned it with the mapping, but then also the accuracy of the documentation that needs to go in for you to get anything of value out of the acuity piece as well. Does anybody else have acuity turned on, or do they be able to talk about?
This is Chris at Covenant. We have a discovery meeting, I believe, next week. So we've got it on our strategic roadmap moving forward just to evaluate, I think with Kyle Besser from Cerner. So we're not really utilizing it today.
Okay.
This is Ray Costanolia from Northside again. We actually kicked off Corvia project. We're on the very infancy stages of it, but we plan on using the patient assignment same also the Acuity. We have Schedule 360. So I'll let the group know how that goes once we really we've kicked it off. I mean, we're in the middle of it right now. We just kicked it off and doing some assessment.
Thanks, Ray. I saw that Brant had to drop, but he did put there in the chat that they went live with capacity management in December. So he said he can maybe talk about that in the next meeting as well, and maybe give some feedback too. Great. As I was kind of diving down that rabbit hole of some of the Clarivia pieces, I was pulling up some of the capacity management and the patient flow pieces. And I think, Jenna, you were working on getting those implemented last time you asked this group, and I don't think anybody else had. Are you still in the implementation process with both of those applications?
We are. And so, you know, it's, and you know, when I'm ready to present, this will be part of the presentation. This is one of those things where we partnered with Cerner, and Cerner went and built and then gave us the dashboard, right? And we were like, we weren't involved in this, so we couldn't validate the numbers that were showing in the dashboard. We couldn't get within like a 5% range with what Cerner was showing and what was actually happening in our healthcare system. So we have now gone back to the table. Cerner has partnered well with us in regards to making this right. And so we are back in at the beginning of the project where our clinical applications team is like connected at the hip with the Cerner team as they go through and do this build. And, you know, and like I said, Cerner has committed to getting this right because there was no way we could launch them the way that they were. They were, quote, ready, but they weren't ready according to our standards. So that's a very important piece when you're contracting because you want to have localization in your contract. So once we get them up, I can report out and even, you know, give you the standard work documents that we have around them for our managers.
That's really good to know about that. So thank you for bringing that up as well. So hopefully anybody else going down that same path won't run into those issues.
Yeah, and if anybody's looking at implementing them, I mean, they are really nice real-time dashboards for your managers for their daily work, for their standard work, to really get a good idea, and also for the executives to really understand at any given time our rates, our line days, how are we doing with getting our falls assessment documented? What's our average time from admission to having that falls assessment documented? All those different components that really drive quality. And so, you know, once we have them, you know, built and localized to Centra's build, you know, if anybody else is looking to do that, I'm happy to connect with you and kind of let you know our lessons learned, so to speak.
Yeah, absolutely, especially that localization piece.
Yeah, this is Ray. I'll be interested to maybe have a call with you. We're in the middle of our, like I said, implementation of, or the start of our implementation with Corvia. So it'd be good to hear the lessons learned from your site.
Okay, absolutely. We're also getting ready to implement the command center dashboard too. So Has anyone implemented that on this call? Okay.
All right, we got a few minutes left, but is there anything else anybody wanted to talk about here?
Hey, Brian, can I bring one thing up?
Oh, yeah.
So a lot of people have said that they found the site information spreadsheet that we put together useful. Having said that, there's a lot of sites who we haven't got updates from. I think we should send it out again and ask people to update it. Like there's a few people on in this call where we don't have the information for their sites, or there's some sites that are on the CNIO that haven't updated in a long time on it.
Yeah, I think we maybe sent that last time, but I'll send that out again.
Did you get anything back from anyone when you sent it out? Because I know I didn't.
No, I didn't. And I can certainly work with anybody, or if you want to pass that off to somebody else on your team, I think that type of information that's in there is valuable to all of us. So, you know, what Chris was talking about, who's using the upgrade center, or who has capacity management or the ClearVia pieces in place. I think that's all valuable to us to be able to start connecting with some of the other organizations on this call as well. So I can certainly work with somebody on your team if you want to pass that off as well when we go and send the notes out to everybody. It sounded like somebody else maybe had a question or a comment.
Hey, Brian, it's Ray again. I just wanted to know if anyone in the group is using or implementing Care Predictor. I believe that's kind of the replacement for Apache. And not one for one, but I think Cerner is doing away or have gone away with Apache and incorporated that with their Care Predictor product. Has anyone started implementing that in your site?
This is Jenna from Central. We have not started implementing it, but we are in the discovery phase of it.
Okay.
So how far are you in the implementation?
We're not far. I mean, we are also in discovery phase. We had some calls with them, and they did a demo for us because our site, you know, our physicians are, you know, really looking for the Apache, to use Apache, but they don't have that product anymore. So they demoed the Care Predictor, which is something I think from the most sites they said that it's they're partnering with VA. I don't know if VA started or in the middle of implementing it also. But they're saying that you can run it in the background, not really have it face up yet, just to see how useful it's going to be. So that's kind of where we are, is we're trying to decide whether or not to run it in the background. So just curious to see if anyone else has partnered with Cerner on this.
Ray, as you get that going, maybe that's something you can bring back for the next meeting if you decide to go run that in the background. And then I'm sure anybody who's running Apache will start to migrate over to that. So I'm sure this group would like to hear anything that you have coming from that too.
Sure, happy to.
Awesome. All right, well, we are here at time. Thanks again, everybody, for your participation this morning. We will work to get some notes put together on this. There's a couple folks who are going to connect. I'll go send some emails to that to make the connections between you. But thanks again, everybody, for joining this morning, and have a good rest of the day. Thank you.
Thank you.
Bye, everyone.
Bye.
Thank you.